I just want to say something about the general overview of things is that, obstetricians and by affiliation, ACOG and midwives, they've been trained differently, and you tend to see things by the prism of how you've been trained. Doctors are often trained in fear-based, high risk, everything's a problem medicine, and that's how we were all trained in residency programs. And we rarely saw a normal birth. Well, you're shaking your head, but we rarely saw a normal birth. We rarely did those things. Midwives are trained in normal birth. They see the prism through normal. So we live in a fear-based world where we're worried about being sued. We're worried about safety. We're not the only purveyors of safety. Everybody wants safety, but midwifery is not a subset of obstetrics. It's a whole different approach to a woman's health. It's like saying organic gardening and industrial farming is a subset of industrial farming. It's not. It's a whole different aspect of the same thing. And I just don't think that when we use the word safety, we want another layer of safety. What I hear when I hear safety is I hear fear. And I hear fear in not just in the population, but also in the medical community you can't legislate out stupidity, and you can't eradicate safety. It's not, you can't eradicate bad outcomes. It's not going to happen. So by seeing a physician, and sometimes it's the wrong physician, a seed is planted in that woman early in her pregnancy that she's got a problem. And that seed grows throughout the pregnancy, and then the pregnancy becomes altered in some way, because if you don't have comfort and confidence when you're in labor or when you're in pregnancy, then labor becomes dysfunctional and pregnancy becomes dysfunctional. I've seen it 1,000 times, and I've been, like I said, I've been backing midwives for 25 years. I've collaborated with them for 19 years. I see a difference when you treat women and reassure them that things are normal. We're the experts in abnormal, and when things don't go well, we see that. When we keep wanting to put more and more layers of safety on things, you're actually pigpiling fear.
I have to keep bringing it back to the statute. Is previous unexplained neonatal mortality or stillbirth likely to impact the pregnancy?
Can I speak to that particular?
If you can speak to that particular
what
issue.
What it says to me is that it's unexplained, that they've tested and they've looked and they've examined and there is no explanation. And it's up to the care provider to offer her all her choices to do extra, or she may choose not to, because some things happen in Mother Nature that are not explainable or preventable. And it wasn't that her care was bad and something was missed last time. So, I mean, to me, unexplained, if everything was examined and looked for and tested and autopsied and, laughed out, well, to me, that's an explanation. Dr. Adams?
I think the answer to your question is no, it's not likely to affect the pregnancy. And unexplained could also be uninvestigated. But even investigated, it's not likely to affect the pregnancy.
I would just add to that too, that many women who have some sort of unexplained stillbirth or neonatal mortality or things like that are going to want to consult with an obstetrician, maternal fetal medicine. Many of them are, and we all know that there are also women who are not going to want to go down that path. And so forcing those few women who have already experienced kind of the worst outcome there is, forcing them to go down a path that they may be trying to avoid in the first place by having their baby and their pregnancy and everything nitpicked to death to build that fear. I completely agree with the fear-based issue. I don't think that serves women, because a huge majority of those women are going to want to explore those, and we're going to support them through that exploration by helping them find the best OB, the best maternal fetal medicine specialist in our area to explore those things if that's what they want to explore. And if they don't want to go down that path and unturn every possible stone of what it could possibly be next time, I think that should be okay. They should be allowed to not go down, be forced to go down that path by us having regulations that require us to make them do that.
I also have a question about if you're an obstetrician and somebody comes to you with this history, how comfortable are you in saying, well, I don't think it's likely, but I don't know. I mean, mean, it seems like in terms of liability, that that's one of those places where you incur it for no good reason.
I mean, just to respond to that, I mean, I think it depends on what unexplained is. If there in fact is a full evaluation and it's all negative, as opposed to uninvestigated and baby was born with dead, so you can't tell what happened. So what does unexplained mean? Dicing words.
Could be that this category, it's just too all-encompassing, that it doesn't really serve what we're trying to do. Because if that phrase, as it is not supported by peer-reviewed literature.
I think I can help us out of this one.
Yeah.
A previous neonatal mortality or stillbirth isn't really a pre-existing maternal disease or condition. It's a condition of the fetus or the infant. It doesn't have anything to do necessarily with the mother.
Well,
it can, but have we not covered that ad nauseum with the rest of the list?
But, I mean, if you want to try and get this resolved, is there a 50% likelihood of recurrence? No.
Good. Good answer.
We're striking that then.
History of postpartum hemorrhage requiring transfusion.
We already agreed
So that one was deleted in the last interested parties meeting, and again on the phone calls, ACOG had some different things to say about that one, so maybe they could speak to that, why they wanted to keep it.
Say the same thing I said with all of these, it's a patient safety issue, and the recurrence rate is high enough that it's, I mean, when you require transfusion, that's obviously, I think it used to say history of significant postpartum hemorrhage, and we tried to change the wording to requiring transfusion to help define the term significant, and I think it looks like it's keep and keep on the right-hand side. There were a number of things that, on phone calls that came up that we were told were being deleted by agreement, and at least some of the ACOG folks, and I was not part of those discussions, and Dr. Drake wasn't either. The folks didn't seem to have a different recollection of what was being deleted, so I'd be concerned about the deleted column. But I think this one we tried to hammer out the terminology and got rid of the word significant and added requiring transfusion, and I think everybody agreed with that.
What do you know what the rate of recurrence of a postpartum hemorrhage is? I guess I have to come back to, what are you going to do differently for this woman? Because you can't predict that she's going to be the one that has another postpartum hemorrhage requiring a transfusion. So seeing her before she even enters our care, I don't understand how that's going to change anything that anybody does.
And I remember this discussion, part of this had to do with how the placenta is removed, and that it's a very different experience, so I'm told, with midwives than
There's lots of things that can cause a postpartum hemorrhage that are iatrogenic in nature. In other words, induced by the care provider. And without parsing all of those out, it's sort of hard to include this, I think. I mean, can I send a woman to you and you can say, oh, no, I don't think that your previous hemorrhage requiring a transfusion is likely to affect this pregnancy. You can't, because you don't know. Because until she hemorrhages, we don't know whether she's going to be somebody that hemorrhages again. I mean, there's just no way to know that.
That's true for everything. Nobody can predict the future accurately.
I mean, you can't even predict that with good consistency. You know, you can't. You know, I had a postpartum hemorrhage that didn't require transfusion, but my hemoglobin went down to 8. Does that, I refused a transfusion. So, I mean, this is something that in my experience should be left to the judgment of the midwife as to whether or not it's going to be something that impacts the current pregnancy. It's not something that is likely to impact it. It's not gonna happen 50% of the time.
I think one of the issues we're coming up with on these types of items is that ACOG feels that it would be safer for a woman who had a history of postpartum hemorrhage requiring transfusion to give birth in the hospital.
Right.
And since it's not on the list of reasons women would not legally be allowed to use a licensed midwife for their birth, this is the only way that they have left to try to urge that woman to choose to have a hospital birth is by requiring her to have a consultation. But once again, that assumes that the midwife is not capable of going through a complete informed consent based on an examination of the woman's history and the specific factors involved and her risk of a repeat and the differences in the ability to treat that based on home birth versus hospital birth. And again, I think that informed consent is where we excel professionally.
And is this likely to impact the pregnancy? Are we going to find the studies that support that? If not, it's got to come out.
She's at increased risk compared to somebody who's not had
Right.
a hemorrhage previously. However, the absolute risk is still low.
And again, you may choose to refer this patient anyway, but as far as it being on this list, do we have to have it on this list?
No.
So if it is off this list and it goes for the 45-day comment period, is ACOG going to have a study that tells me it has to go back on the list?
I mean, we would probably ask our experts in DC to comment on
Okay. Our physicians aren't aware of
I
studies.
think she's more likely to have another postpartum hemorrhage delivering in the hospital, honestly. Well, you know, she had a postpartum hemorrhage, let's get the placenta out, let's, you know, so we're going to pull out the placenta, we're going to do all the things that are going to increase her risk of postpartum hemorrhage. We're not going to give her, an obstetrician I doubt is going to recommend that she take red raspberry tea or alfalfa to decrease her risk. So, you know, but, you know, you're going to give Pitocin. And so I think, I'm really passionate about this one. I think this should be completely off the list because I think most postpartum hemorrhages are iatrogenic. If she develops a fever, which increases the risk, she's going to be in the hospital, right? You know,
Okay, number 16, essential hypertension, blood pressure. What's that? Okay. Blood pressure greater than 140 over 90 on 2 or more occasions, 6 hours apart. Fine. Okay.